Welcome back to episode 5 of the Rehab Exercise and Sports Therapy podcast. I'm joined today by Dr. Raymond Hsu and Dr. Brad Blankenhorn of University of Orthopedics, both respected foot and ankle surgeons. Today's topic is going to be acute Achilles injury. Obviously, Achilles covers a wide span and diverse array of things, including some chronic and degenerative issues. Today, we're going to focus more on the acute injuries. So if you guys could, I don't know who wants to go first. We did not do the coin flip or steel cage match, but I don't know which of you wants to go first and introduce yourself here.
Sure, I'll start.
All right.
My name is Brad Blankenhorn. I'm the head of the foot and ankle division at University of Orthopedics. I am fellowship trained in both orthopedic trauma and foot and ankle surgery. I've been practicing for about 12 years and am very happy today to be here discussing acute Achilles tendon injuries.
Excellent. Thanks. Dr. Hsu, could you give us a little bit of background?
I'm Raymond Hsu, similarly trained in both orthopedic trauma and orthopedic foot and ankle surgery. I've been back in this group for 7 years. And again, this is a very interesting topic, and happy to be here.
Great. I'm looking forward to hearing both of your perspectives today. So if you could give us a little bit of background about how Achilles ruptures happen. We know predominantly it happens significantly more to males in their 30s and 40s. And we know the Achilles has, kind of a watershed area with decreased vascularity. But if you could tell us kind of what's the mechanism and what makes the Achilles potentially more susceptible in those demographics.
Sure. So, middle age is the peak of the occurrence of Achilles tendon ruptures, but they can happen in teenagers and patients that are older. The studies would tell you that the underlying tendon material is not normal prior to the rupture. So there's probably some underlying physiologic mechanism or physiologic process going on that causes the tendon to be weaker. And usually, however, that process does not cause antecedent pain. So most of the time, people aren't feeling symptoms prior to the rupture. So it usually occurs after an explosive plantar flexion or pushing off event. And, the patients will very commonly describe it as they felt like they were kicked in the back of the leg or someone hit them. They'll feel or hear a pop and, have a significant pain at the Achilles tendon itself. So there's probably some predisposition to it, but it's hard to predict who's going to have that predisposition. And if we could predict that, then there might be some interventions we could do to prevent it from happening, but it tends to be pretty much random.
Yeah. So tell me, once, from your standpoint, from a clinical standpoint, once someone tears and they come in to see, what's the value for you in imaging studies? Do you use it? Because I know, in reading there is the possibility of partial tears or tears instead of, a couple of centimeters up from the attachment, tears at the musculotendinous junction, right? Which I know are more problematic. So tell me, is that part of your practice, and what is the value in it for you?
I'll take this one. I guess for the average middle-aged or younger patient, if there's a palpable defect and on examination confirm the diagnosis, and by palpation you can figure out the location of the rupture. And there's a test called Thompson test where we have them lie belly down and squeeze their calf muscle compared to the other side. It's different. That combination there is pretty diagnostic, and we generally do not get an ultrasound or MRI to confirm diagnosis. There are certainly exceptions, and the two more common exceptions I can think of, Brad, you can chime in. One is if you can't palpate the level of the injury, but the exam is confirms the rupture, but we can't confirm the location, the level of the injury. That kind of alludes to your more proximal tears. It's generally not a partial tear, but a more proximal tear, or very distal tears. If we suspect a more distal tear, imaging can be helpful in terms of determining or confirming that's distal tear, because the repair and treatment may be very different. And here we're talking about ultrasound or MRI. We often do get an X-ray just to confirm there's not a bony injury.
Right.
Yeah, I think that a partial tear is not really a rupture. So it's probably a different process. Like maybe there's
Sure.
some underlying chronic tendinopathy.
Okay.
That's truly the situation. It's kind of like being pregnant, like it either is or it isn't, in my mind.
Sure.
Most of the time, physical examination is enough. I, like Dr. Hsu, get x-rays for everybody to rule out fractures
Yeah.
or a bony avulsion from the calcaneus. Um, the only time I get an MRI or ultrasound is like he said, I can't localize where the rupture location is. I get it. And if the story's a little off, like if it's a classic playing basketball on the weekends, the first time I've done it in 10 years, and I felt a pop like somebody kicked me, then, pretty much that's it.
Right.
But if it's a little funny, then maybe I get an MRI. There's maybe one patient who's had kind of a partial tear that, was proven on the MRI, but his exam was much more consistent with like a normal exam. So not frequently, and certainly not required to understand the diagnosis and the treatment.
Got it.
And
And
partial tears are much more rare in the younger population. I mean, I think that's kind of alluding to the patients with tendinopathy already, and then maybe they have a degenerative part of the tendon that then ruptures in older population. So yeah, I can only think of maybe one patient also off the top of my head with a partial rupture, like a true partial rupture.
yeah.
Yeah,
Okay.
so that brings up a good point though about the older population, because I do think their mechanism is different than a 45-year-old. They don't like blow it apart and you get a palpable gap. Sometimes it just kind of slowly stretches out and becomes basically a rupture, but it doesn't separate like a, explosive rupture like a middle-aged person or younger person has.
Yeah.
They can be a little tricky, and certainly an MRI can sometimes be helpful for them.
Got it. So let me ask you now, on as far as the mechanism goes and being able to palpate that defect or that kind of thing in the tendon, is there anything prognostically that correlates between the amount of gapping in that tendon and how they do outcome wise, whether it's surgically or non-operative management, or is that kind of just a non-determining factor?
So the palpable gap is probably really a very blunt tool for deciding that.
Yeah.
But part of the examination is not only the Thompson test and the palpable gap, it's the resting position of the patient's foot. So if their foot is in a increased dorsiflex position compared to the uninjured side, then it's highly suggestive of the extent of lengthening of the tendon. So you can have a rupture, positive Thompson test, but your overall length is maintained. I think those are patients who are going to be a better candidate for non-operative management if they choose to go that route. If somebody has an increased dorsiflexed foot, then that tells me their tendon's already stretched out and it may not heal. It may not get to a position where it's at an appropriate length without a surgical intervention.
Perfect. Okay, you just segued for me perfectly, Dr. Blankenhorn. So into the discussion of someone comes into your office, right? So who do you counsel? Who's the ideal candidate for surgical repair, and who do you maybe try to subtly nudge or encourage to get the non-operative conservative management? How do you make that determination, besides someone coming in and demanding the repair, right? What factors play into your consideration or your algorithm with that?
Brad, you gonna take this one?
All right. So, one, you never have to have your Achilles tendon repaired. It could
Right.
heal without surgery. I never recommend it to a patient. Obviously, you have to take in their overall activity level, comorbidities, medical problems, age, all those things factor into decision-making process.
Okay.
If And probably the most important thing is the activity level and how they want to face the injury. The downside to treating it non-operatively is that there is probably some higher risk that it maybe heals in a less than ideal position because you're requiring a boot or cast or something to hold it in place, which is not as reliable at re-establishing the length of the tendon as surgically repairing it.
Right.
So they have to be willing to accept that risk. And some people are, and some people do superbly well with non-operative management. If all things are equal and you're a 40-year-old male, same medical history, same activity level, and your exam is consistent with a rupture, like we were just talking about, if it is lengthened, then I'm more concerned that the boot may not be able to correct that lengthening in and of itself, and that surgery may be a better option to control the healing a little bit better. Um, Still not required. The boot can sometimes correct it, right? But you have to take on the risk that maybe it doesn't. So I think that if somebody, the ideal non-operative management is that, hey, it's ruptured, but the length is good. We just have to hold it here. And there's probably something in the injury that didn't distract it a lot that gives it a better chance of healing there. Somebody who really blows it apart and it's already lengthened, or if it's been a period of time, like a week or two, where it's already started to heal and scar in a position that's long, then it's going to be more likely to undergo surgery. Like, the delay in diagnosis and appropriate treatment, with an elongation tells me that the boot probably will not correct the problem and that surgery is more likely the better option, although not required.
I agree with everything Brad said. And I want to emphasize that the timing, I think the people who have a delay in diagnosis or misdiagnosis and have been walking around without a splint or boot in a plantar flex position are, you said the ideal candidate. I wouldn't call it the ideal candidate for surgery, but I would say that's someone who probably more likely to benefit from surgery.
Got it.
Than someone who was identified right away, wasn't elongated, and was in a plantar flex position early on, and that person has more options. At least they have a decision they can make with probably a reasonable outcome with both treatment options, versus someone where it's already elongated, delayed diagnosis, which I counsel patients. It happens quite frequently. I don't know what your numbers are, Brad, but I think there's some studies, and at least in my office, it's probably like 10 to 15% of people come in with delayed diagnosis or misdiagnosis. It's not that uncommon, really.
Yeah. So tell me, if someone were to be fixed surgically, what's the window? Like, how long is too long before that tendon is scarred in or retracted, or, again, overly lengthened to where it's just going to really limit their surgical outcome?
I don't think I don't think the window is like a clear-cut defined time
Okay.
frame. I think it's more and everyone's different, but the longer the time frame, the surgery can, for some people, be more complicated because you have to mobilize the tendon more, and you're facing more time of calf atrophy that's already starting to develop. So then their post-op rehab may be different as well.
More
They're just more challenging because they start off with a little bit more behind the clock. But and unfortunately, we treat them kind of in a broad range of time frames.
Yeah. Okay.
Yeah, I think that 4 to 6 weeks is probably where I start to worry that I might have to do something more to repair it properly, either lengthen it further upstream or augment the repair in some capacity. But there's still the potential that we could do a standard primary repair. After 6 weeks, then that really starts to get more worrisome. But you never know. And after a certain point, you say, well, let's just wait and see what happens, right? Maybe this is going to be okay without surgery, right? Where that point is different for everybody. And that's certainly somebody who shows up late, you're getting an MRI to get an idea what's going on, maybe, or an ultrasound. But 4 to 6 weeks is the time frame that you would like to, at the latest, to fix it or repair it. But ideally, I mean, I don't wait. I try to get people into the operating room as soon as possible once we confirm the diagnosis and make a decision, because I think that there's no benefit in delaying the repair. And the longer you wait, the more atrophy they're dealing with, and the harder your job is, Dan, to get them back to strength, right?
Right. So just for our audience here, who maybe consisting of rehab professionals and even some lay people here, in terms of comparing and contrasting non-operative versus operative management, how do the immobilization timeframes compare? I mean, obviously the surgical repair is going to be a little shorter as far as the time you're immobilizing them, right, before you really get them, get the ankle moving. But what's a reasonable time frame with both of you, with your protocols and expectations? And obviously some of it may depend on what you had to do surgically, but for your let's say standard straightforward tear.
Yeah, so for a standard straightforward repair, and Ray and I are very similar in this. And we're also both very conservative because I will take a little bit of extra weakness and stiffness over a stretched out repair.
Right.
So there's not a huge difference between operative and non-operative management. It's slightly faster with non-operative or with operative management.
Yep.
Because ultimately surgery does not repair the tendon. All it does is hold it in a position where it can heal and control the healing position better, but it still has to heal. There's still a risk of re-rupture with it, but it's probably a lower risk with surgery compared to non-operative management.
Right.
The difference with surgery is that you have to protect an incision so that they are required to be in a splint and be non-weight bearing for 2 weeks to protect the incision. Early weight bearing is beneficial for tendon healing, so we both start them weight bearing, protected in a boot after the 2 weeks of immobilization with heel lifts to protect the repair as well as the incision. And then we do that. I do that for 4 weeks. I have them treat that similar to a cast. So they sleep in it and they minimize range of motion, although I know that there's probably some motion that's happening and probably lots of people don't sleep in it. And then after
Yeah.
4 weeks, I take out one lift to drop it down a little bit and start gentle range of motion exercises on their own. Goal being to get to neutral 90 degrees of dorsiflexion by 10 weeks postoperatively. And then at 10 weeks, the last lift comes out and they start weaning from the boot, which they usually do fairly quickly because they're very frustrated with it at that point. And then initiation of physical therapy for strength and range of motion without many limitations other than explosive jumping or running until about 5 to 6 months. With the non-operative management, it's the same steps, except there's no splint. It's 6 weeks of being in the boot like a cast with the 2 lifts, and then 6 weeks doing range of motion with one lift, and then that gives you to 12 weeks postoperatively. So slightly faster with operative management compared to non-operative management. And I think some of our non-foot and ankle partners or other providers might be a little more aggressive with weaning from the boot, but like I said earlier, I want it to heal at the right length, and we'll take a little longer rehab to get there.
Sure. And would you say overall, again, comparing the two, is it reasonable to say that on the whole, those that have non-operative management should probably expect a little more weakness down the road than those that have it surgically repaired?
No, I mean, I think
No.
that
Okay.
so say both heal at the right length, right? I would expect similar weakness, and I counsel patients to expect 20% loss of strength and calf atrophy at a year. Where it is, or 2 or 3 years after that, anybody's bet is, how long it takes to get to the, more normal and what their new normal strength will be. Both can be successful. What you don't want is elongated healing where you can't get to that 20% of the year and you can do all the rehab you want and you can't get the strength back. Like that's what we don't want. That's what we're trying to avoid with our decision-making process for the acute management.
Yeah, I was definitely going to touch on that a little bit in the rehab section here when we get to that. But I mean, then it becomes essentially like a loose guitar string, right? Where you've altered the length tension of that gastrosoleus complex, and it's a losing battle trying to get the strength back in there, right? So, um, on that note, right, we discussed a little bit about operative management. I know that recently there's been in the news, right, a kind of increase in the ways that you can potentially repair Achilles, right? It's kind of morphed maybe from open to some people doing the percutaneous or minimally invasive technique now. And thanks to Aaron Rodgers, right, we now know about the speed bridge and some of the other ways that you can, or some of the other technologies, surgically you can potentially use to possibly speed or enhance recovery, right? So could you tell us a little bit about some of the different variable techniques and which you guys use and why, and if there's a gold standard or if it's kind of all over the map?
So I guess I'll start with this one. I mean, going back to what I think Brad mentioned earlier, the idea of repairing it is that we're not replacing the tendon, right? The sutures are just holding it internally like a brace. So I tell most patients that, they really want to understand it. The sutures are acting as the boot or cast, but on the inside. The same way when we fix the bone, the plates and screws are not replacing the bone, but holding the bones in place so they'll heal. Yes, there's definitely like the traditional open, there's a mini open, there's percutaneous, there is speed bridge, which is a variant of the percutaneous. But in the end, all of them are really just in using suture to hold the two tendon ends together tight enough at the right length, hopefully, and hopefully not have them stretch out over time during the rehab. There's some interesting studies out there about, how long they can stretch out for, maybe up to 6 months. There can still be some additional stretching. I think both of us still do kind of a mini open technique where we try to make as minimally invasive incision as possible, but using locking sutures because we both feel that that gets us the best purchase in the tendon to buy the patient the most time to heal it up, without the risk of a large traditional incision, but theoretically with more purchase, more capture of the tissue than the percutaneous techniques. But they all have some risks. Like none of them are as surgically risk-free as not having surgery, for example.
Right. Yeah. Understood. Yeah. I mean, so on that note, right, some of the risks I know are sural nerve complications, right? And then, obviously one of the benefits of the smaller incision is decreased risk of infection, right? With that tendon being so superficial, obviously if that becomes infected, that's an enormous problem, right? So, how, in terms of fixation strength, or is there any long-term data on differences between those techniques, or is it kind of equivocal?
Well, so I think you have to remember these tendons aren't like cleanly cut. They're like
Right.
shredded. So my concern has always been in the, minimally invasive procedures I have done. You're not like when we do an open procedure, you're sewing onto the suture itself as well as the tendon. You're like reforming and tubularizing the tendon when you do that. The percutaneous techniques, I feel, just don't do that as well. So I
Right.
feel the quality of the purchase of your sutures and therefore the potential for them stretching out is higher. So, like Ray said, we both do kind of a mini open approach, trying to minimize our incision. However, the underlying reason we would extend or enlarge an incision is to improve the purchase of our sutures to decrease the risk of it stretching out. With the
Right.
percutaneous approach, I feel like you can't really control for that much. So you kind of are hoping that you get a good purchase with this, and the whether you put in sutures above and below the rupture and tie it, or whether you put in sutures above the rupture and put it to a bone with an anchor, you're just holding it in the right place, and it's only as good as those sutures going through the tendon. The study would tell you that minimally invasive approach probably has a little bit of lower risk of infections or wound problems, and but a higher chance of sural nerve injury.
Right.
They seem to be equivalent as far as their healing, but I think that every study has its biases and downsides, and
Sure. Yeah.
often these studies are supported by the company that makes the devices that allow for these minimally invasive approaches. So I've been happy with the repairs I've been obtaining with an open approach. And yes, there are infections and they are catastrophic problems that really impact the outcome. But I do think you also avoid the stretching out issue, which is not a good outcome also.
Right. So, in terms of enhancing that healing, obviously orthobiologics are a huge thing now. But I'm wondering if you can tell us about the value of orthobiologics with Achilles repairs, PRP, stem cells, anything that either of you use in your practice, and maybe a why or why not, pro or con kind of rationale, maybe.
Yeah, I don't use anything. Obviously, surgery creates blood, which is basically what PRP is.
Yeah.
So I don't see any real benefit of augmenting that in any capacity.
Okay.
I certainly would not recommend wrapping the tendon in like a dermal graft because that is a big problem if it gets infected, and you can really, really have a bad outcome. And I
Yeah.
don't see how that enhances the healing at all by wrapping dead something around the tendon. So I don't use any biologics. I just rely on the patient's healing. I mean, fortunately, these are usually healthy younger patients that have good biology. If somebody needs to augment that biology, then maybe they shouldn't be having surgery. So
Yeah.
so due to the increased costs and unclear benefits related to them and possible some increased risks with them, I don't do anything. I think Ray is doing similar.
Yeah, I don't think there's any data to show any benefit from PRP, or like I don't know, all sorts of membranes that people are using. I think if
Yeah.
someone's biology is if someone's has a poor biology but presents with a delayed Achilles rupture and really would benefit from surgery, that's often someone where we would consider an FHL transfer, where you're taking some better tendon and muscle adjacent to it and using that. I guess you consider that a biologic, but it's using their own biology. But it's also more of an internally adding more mechanical strength by bringing the tendon over as well.
Okay, well, that makes perfect sense. So since we have kind of a largely rehab audience, I was hoping that we could kind of get into some of the nitty gritty and your feelings or precautions about what to do or what not to do rehab wise. But we know, as we've alluded to already, one of the biggest issues that we face that can really kind of destroy the outcome is tendon lengthening. So if you could kind of tell us a little bit about some rationale or theories about why does it happen following the repair, and is it something that's avoidable, whether from a surgical or rehab standpoint, or is it kind of an inevitable consequence of just repairing somebody's Achilles?
Well, I guess in terms of the mechanism, I guess we don't know for sure, but there's at least two possibilities, right? One is that you're repairing it. Well, we're talking about surgical repair at this point. So even if you back it up, the suture could potentially stretch out or break over time. But even if the suture never breaks, really you're taking suture, which is basically just thread, and you're putting it in through soft tissue, and then you're starting a rehab with strengthening. Even if you're very careful when you do strengthening, with each strengthening cycle, there's some creep, and that suture can move through the soft tissue. Which is the idea behind open approach and having locking sutures in there, having more purchase, because we want to get as many cycles as possible before it potentially loosens or stretches out. I think it's inevitable, and there's some interesting studies out there where they implant little metal beads at the repair site, two separate sites, and then they measure them on X-rays over time, and they've shown that even up to 6 months out, they can still be spreading apart. So I think some of it's probably normal and some of it's probably like unavoidable, but you just don't want too much of it. Otherwise, you kind of lose the whole purpose of not just the surgery, but the initial rehab protocol we went down, non-rehab protocol.
Yeah. And Dr. Hsu, am I correct in that study that the most lengthening that happened was in that first 6 or 8 weeks in that study, I believe, right?
I believe so. I think so. I think most of them may be even in the first 3 months, but they found a difference between 3 months and 6 months as well.
Yeah. Okay. So on that note, if you could tell us, for our rehab audience, tell us your feelings on, because again, I think the naivete is that we see something that's stiff as therapists, and sometimes we want to stretch it, right? So we want to get their motion back, right? So tell us, when do you feel like it's safe for somebody to really start getting into more aggressive range of motion, and how long do you want them limited? Do you feel like it's safe for them to dorsiflex beyond neutral? And then when do you think it's safe for that person to really get into something, more aggressive that may stretch out that tendon a little more?
Yeah, so and Ray may feel different about this, but we touched on it a little bit earlier. Like, the reason I don't start them in therapy until 10 weeks is as I let them protect themselves for that time frame. I feel like they're probably not going to overdo their range of motion if they're doing it on their own.
Yeah, actively definitely makes a difference.
Yeah,
sure.
And I haven't had anybody really overdo it yet, get to the point where I'm like, oh, this stretched out because you were doing too much with it during those first couple of weeks. It's limited by pain and, just their apprehension probably about overstretching it. After that 10-week mark, I feel pretty confident that you can stretch, not aggressively, but like reasonably, progressively, without overdoing it. Obviously, there's probably some contracture of the initial repair that occurs, which then needs to kind of stretch out a little bit, which is probably fine, like we were talking about the last question. But overstretching is what we're trying to avoid. I tell people that, I don't want any explosive jumping or running until about 6 months. After 6 months, I think their risk of re-rupture is probably back to their baseline. There are certainly people that do it earlier, either on their own or at the direction of the therapist, and I haven't seen a problem. But there's probably a re-rupture risk for, a certain period of time, which is highest probably at like 6 weeks, but probably still there for a while. So I try to avoid really aggressive activities till 6 months. That's a slower process, right? and it may save a couple people from having a disaster, but it
Right.
makes it a little bit slower for everybody. So, but I'm comfortable with those time frames.
Yeah, I agree. I have patients. I mean, if you think about it, once they start walking without the boot, which is somewhere between 10 and 12 weeks, they start walking without the boot. Every step, they're stretching a little bit beyond dorsiflexion as they're
Right.
getting
You're
up
going
rises.
beyond neutral. Yeah.
Yeah. So, but actively, like purposely, intentionally working on stretching, I don't know. I tell most patients I'm perfectly happy, and if they try to give them peace of mind that they should be perfectly happy being a little bit stiff, even up to like 4 months out.
Yeah.
I try to follow my patients up to 6 months out, and if they're still having problems up to a year, I haven't seen anyone at endpoint where stiffness is their major complaint. It's usually still working on strengthening, still working on getting back to their previous level of function. But very few people after an Achilles repair are saying, I'm now 12 months out and I'm strong, but I just feel like it just feels stiff. That's not the most common thing we hear. I mean, I'd be interested to see what you think, or a physical therapist here on your end.
I was just going to talk about that. I actually love it when they at the 3 month mark when they tell me that it feels stiff. I'm like,
Yeah,
great, because I feel like they do better from a strengthening standpoint. I
right.
feel like it's to some degree. I mean, I feel like with further time out from surgery and kind of restoration of normal activity, I feel like they're going to find their way back to that, endpoint or, wherever they are tissue laxity wise anyway. And I just get more concerned, like we've already alluded to, that, the person that tells me, oh, it feels great and it doesn't feel stiff at all, I feel like I worry about that person, like you talked about, over lengthening and, having significantly more difficulty restoring that length and tension to get full strength back in there. So,
Yeah, and Brad brought this up, but I mean, I have seen some patients who are doing box jumps at like 4 months. They're doing like really crazy explosive things, and their physical therapist like really got them to that point, or they got themselves to that point. But I tell them that like they are putting, I think they're putting themselves at risk. Like that, like kudos to them and kudos to their physical therapist getting them there. Like that's a lot of hard work, and it's amazing they did it without complication. But that's definitely, I think they're pushing the envelope a little bit. They're putting a little bit of little bit at risk, which is, I don't know, that's a personal decision about whether they want to do it. It's definitely not what's prescribed.
yeah, sure. And I get it, on some level, I feel like a lot of these people that are opting for repair are opting because that's what they're hoping to get back to. But yeah, I feel like it's a balance, right? I mean, you don't want to do that surgery twice, right? So, yeah. So tell me a little bit. We talked about the weight bearing and the progression, and we know that like one of the worst things you can do is just completely immobilize a tendon, right? And not give it any stress, right? So with the weight bearing progression, what is your feeling about when you're comfortable with them beginning any kind of resistance training? Especially in this case, resisted plantar flexion is obviously the biggest consideration.
Well, basically, I think I get the physical therapy around the same time Brad does, around 10 weeks out from the surgery, or
Yeah.
10 weeks out from immobilization, 10 to 12 weeks from immobilization, like initial injury, if they went the non-op route. They're working on strengthening. So I think by definition, they're working on some resisted plantar flexion at that point. I usually
Yeah.
tell them to
Okay.
go from the neutral down to plantar flexion, which they want, whether it's, against resistance bands, um, as long as they're not stretching it out.
Right. Okay.
If they start earlier.
Yeah, I mean, I think there's like closed chain activities, right? Which I feel pretty safe with after the boot kind of goes away. And
Yeah.
then there's more explosive pushing off, which is a little bit different, but like a resistance to a band or even, calf raises with a weight, I'm fine with progressing based on comfort,
Yeah.
after the 10-week immobilization. Box jumps, maybe a little longer. Yeah.
Sure. So tell me, I'm curious to get your perspectives because one of the emerging kind of modalities or treatment, kind of augmentation or enhancement things we offer with physical therapy is blood flow restriction. And I'm sure you've probably had some patients asking about or some therapists doing it. So I'm curious your feelings about use of blood flow restriction training in rehabbing the Achilles repairs. Or
Yeah, so
do you have a feeling one way or the other?
I don't, it wouldn't be something, at least with the information that I have currently, that I would recommend.
Okay.
My understanding is that it can enhance muscle bulk, but not necessarily strength, if I understand it correctly. So I tell them, it's not part of my normal protocol. I can't recommend for or against it. If you want to try it, that's okay, but be safe with it and, be cognizant that you don't have to do it.
Yeah. Dr. Sue, any thoughts one way or the other?
Not really. I actually honestly haven't had any patients bring it up.
Okay. Oh, interesting. Okay. All right. I feel like the problem is that it's been studied a pretty significant amount at the knee, especially with regards to ACL reconstructions, but I feel like there's just not any significant evidence and definitely a scarcity of data on it other than probably case studies using it for Achilles. So I feel, I mean, I can see the rationale for why people would use it, but I don't know that there's just enough evidence to really fully support it yet. So, and especially depending on when people are implementing it, but we talked about the infection risk and that kind of thing. If you're doing blood flow restriction training early on in the rehab process, where you can potentially, cause drainage or issues with that incision, I feel like that's definitely something I would stay away from. But I was just curious if you've had, any thoughts one way or the other about it.
When would it typically be initiated?
So it depends. Again, like with our ACL, sometimes we wait till about 2 weeks out, 2 to 3 weeks out till the incision is fully healed. Um, but probably less of an issue for you because by the time if you're starting patients at 10 weeks, you're not running into that issue. The incision's well healed at that point. Um, but I know there are some physicians that start the patients earlier in the rehab, and there are some places that advocate using it. So that's why I was curious to kind of get your take.
Yeah,
I
I mean,
have seen. Sorry, go ahead.
I think if somebody was going to inquire about it, I would probably not recommend they do it until after that increased re-rupture risk period is over.
Yeah,
So, that's usually at 6 weeks because the tendon actually gets weaker during the healing process. And restricting blood flow during that phase could augment that weakness. So
yeah,
realistically, I think if they were going to do it, and I have no clue whether they'd be even beneficial at 10 weeks postoperatively, but by then I think that acute increased risk of rupture or highest risk of re-rupture period would be, passed. But it's different than an ACL reconstruction, right? It's a
for sure.
repair.
Yeah,
You need the tendon to heal versus just having a piece of tendon in there holding things together, right? You need blood flow for it to heal, right? And obviously, if the risk of re-rupture is higher at a period of 6 weeks, not at time zero, there's some kind of healing process going on there that requires oxygen and blood that you might be disrupting by adding in, some restriction to that. So, probably it needs to be, if initiated, probably after the 10-week mark when that is the biology is changing in some environment.
sure.
Yeah, on the topic of timing of physical therapy, I mean, sometimes we do have patients who really want to see a physical therapist early. Um, and I think that's fine. A couple times I've seen problems with like starting Graston technique or something like scraping around the incision early, and I've run into a couple problems with that.
Yeah,
But the other one is like in the reality of our healthcare system is a lot of people have a limited number of visits with deductibles and so forth. And I think physical therapy can get a lot out of it in that, like after the 10 to 12 week phase. And I hate to see
sure.
people, and not that you can't get something out of physical therapy early, but I hate to see people like use up their visits and then they run out later where they really could benefit from actively. And that's just the
Right.
reality of our healthcare system. Not everyone has a healthcare plan where it's unlimited physical therapy visits that are covered.
Sure. No, I mean, I think definitely how, knowing what they have as far as physical therapy benefits in advance and kind of allocating them appropriately is a huge consideration. So, not starting them till 10 weeks on some level, I think just kind of eliminates some of that need for how carefully you need to allocate them because at 10 weeks, like you already mentioned, they're good to really plow
Right.
forward with the strengthening aspect of things. So,
Exactly.
and then obviously it's kind of criteria based from there, as far as how you're progressing them. But that's a good segue into my next question. So, one of the questions I had for both of you was when do you feel comfortable allowing them to return to run? Because that's one of the biggest questions we get, right? Or return to sport for those people that have been repaired. What's your decision making algorithm or what criteria or check boxes do you need to see them hit in order to clear them to be okay with that?
I think it depends on their sport, and it depends a lot on. Well, so to the topic of running, I usually say it's 5 to 6 months, as we alluded to earlier, before running. But I think it's a very different than explosive things like field sports, tennis, where
Yep.
injuries often happen to begin with. Um, and so, getting back to running versus getting back to sport and like what level they play at is a very personal discussion. I'm sure they discuss with their therapist, but I try to discuss with them about, are you really aiming to get back maximum at some time point within the year, or are you trying to get your maximum possible outcome at 1 year and beyond? And most of my patients are really trying to maximize their outcome, 1 year and beyond.
Yeah.
So I'll kind of play it on the conservative side, maybe start jogging at 5 months, maybe running at 6 months. And then when they feel like they get some good stamina, they can start returning to their sport. But it's obviously sport dependent as well.
Right. So
Yeah.
let's
So I think,
say, I'm sorry, go ahead, Dr.
yeah. So I was going to say that I agree with Ray. 5 to 6 months is usually the time frame, and there's avoiding running due to my concern for damage to the repair, and then there's I don't have the strength yet to run. And they're
Yeah.
two different things. And my concern about damage to the repair is probably 5 to 6 months. In reality, most people come back to see me about 5 months, and the vast majority of them are unable to do a single leg heel rise, which is probably the main criteria for running comfortably without some kind of cattywampus mechanics.
Yeah.
So, when that comes back is probably very variable for everybody. And I probably defer that a little bit more to the therapists, but my criteria for allowing them to progress is usually 5 to 6 months. But in reality, it probably takes them a while to get the strength back till they feel like they're ready to do it. And 5 months, rarely are people running before 5 months, primarily just because they don't feel strong enough to do it.
Yeah, Dan, I'd be
Agreed.
curious
Yeah.
to hear what you see on your side, but I usually see people back for a 6 month follow up. About half my patients can do a single leg heel rise on that time, but weekly, definitely not equal to the contralateral. Like they're just
And
starting.
not through the full arc. Yeah.
Yeah,
Right.
yeah. Like so, about half of them can do it in a weak manner, and half are just maybe getting there. And I tell them not to be disappointed. Like that's kind of like the average at that point, and they're only 6 months in to something that has a minimum 12-month recovery. It's really, in reality, probably beyond that.
Perfect. So you both stole my next question, which was going to be, what do you use for your screening process? But in single leg heel raise, it seems like, is it fair to say that's the gold standard out there for, what we use to determine, where they're at and their appropriateness to be able to kind of really push into those more explosive types of activities?
Yeah, I think that's a reasonable bar to meet before you start doing
Okay.
that. Yeah.
So with that limited ability to restore full strength or, longer time frame for the recovery of full strength, I'm curious, I just wanted to pick your brain with both of you. What do you feel like are the factors that contribute to that? Is it just the tendon length? Is it neurologic? Is there something, I know, again, depending on the length of time from the injury, sometimes there's fatty infiltration and that kind of thing in the muscle. So what do you feel like contributes to that prolonged weakness?
It's a good question. It's probably multifactorial.
Yeah.
I think from our standpoint, what we can control is the tendon length. And that's our main thing that we're concerned about. Because if it's long, all the other things don't matter, right? It's probably
Right.
you could be the best biology ever, and you're not going to get your strength back. So if it's the right length, then why else would you not be able to do it? It could be
Right.
the duration of time from the injury to the repair, and there could be some probably chronic changes within the muscle that we can't improve or rehabilitate ourselves out of. Um, Everybody's biology is different also. Like there's probably some people that inherently bounce back from an injury better than others. Who they are, I don't know. What those factors are, I don't know. So I don't know how to answer that. There's probably lots of reasons why somebody takes longer. Some of it is, motivation and or apprehension about their injury, right?
Sure.
Certainly people who are afraid to walk on it or are afraid to rehabilitate it more aggressively can shoot themselves in the foot, and really impact their overall outcome. So part of, our job is counseling them on not being apprehensive, not babying it, progressively moving it forward and, using it, right? Because in reality, you need to use it. Like I think and Ray has probably experienced this too. Some people run into problems are the ones who don't walk on it between weeks 2 and week 6.
For
And
sure.
then they end up in a different situation. Their whole leg gets too atrophied and they get too stiff and the muscle doesn't, or the tendon doesn't heal correctly. So like part of our job is to encourage them not to be afraid to use it, because I do think that that probably factors in much more than, their biology does. It is their, their mental attitude towards their injury.
Yeah, there's a ton of rehab literature now coming out about psychology and the fear of re-injury or kinesiophobia and fear of movement, that, people get good at avoiding using that injured tissue or your brain kind of finding like a workaround, right, to compensate, or that kind of unfortunately allows that weakness or that deficit to persist. So yeah, that's a huge consideration for us. Yeah, in rehab. And honestly, sometimes those people are the hardest to rehab because again, it's one thing, like you can give them every exercise in the world, but addressing like the psychological fear and apprehension is definitely a much harder task. Um, so you two have been great. I thank you both for taking the time to meet with us today. I did want to kind of get, for our therapy audience, any final thoughts or recommendations or kind of take home points either of you would offer them in terms of rehabbing either the non-operative Achilles managed patient with the acute rupture or the Achilles repair patient? Any real bullets or take homes to really consider with the rehab?
I think other than just not overstretching, which we talked about, but then
Yeah.
also in terms of strengthening, I think there is a big variety in how people progress, which I'm sure the physical therapists already see. I mean, there really is a big difference in people's healing potential, and I think customizing the protocols a little bit, sometimes speeding up by a week or so, or small changes is probably very appropriate, as long as you stick with not overstretching.
Right. Anything for you, Dr. Blankenhorn?
No, I think similar to what Ray said, I think listening to the patients and adapting their rehabilitation based on them is probably very important, and identifying some of those other factors we were just talking about that may inhibit their rehabilitation and trying to counter those in some capacity, that over apprehension and concern. Half of Ray and my job is like almost like a life coach. Reassurance is a lot of what
Yes.
we do, which I'm sure is a lot of what you do too, right? It's
Oh, for sure. Yeah.
a lot of everything is okay, keep plugging along, right? So some people need more of that than others, and trying to give them that on a more individualized basis is probably the best thing that we could offer them from all of our standpoints.
All right. And lastly, something we've kind of added here to our podcast, just going off script here a little bit. If you could share with us some kind of fun personal fact about each of you that may not be in your University of Orthopedics bio or your CV here. Tell us something that the listeners may be interested in here.
Oh man, I'm still trying to convince my wife to let me have backyard chickens. That's my
Backyard chickens. Okay. All right.
Which
Yeah.
Brad has the perfect backyard chicken backyard, but he's not going down that path.
Gotcha. I guess it depends on where you are and the zoning laws and that kind of thing, right? So yeah.
Fun facts.
Backyard chickens. I like it.
Fun facts I'm supposed to talk about.
I'm waiting, Brad. I'm waiting.
No fun facts. Uh,
The word on the street, Dr. Blankenhorn, is that you may be a Penn State fan. Is that correct?
that is true. Yeah.
Yes. Okay. How do you
yeah.
feel about them this year? Is this year they might be able to take out Ohio State or no?
I mean, any given day, you never know, right?
Well,
So,
true.
yeah,
Yeah.
right. You never know. I don't know. It's possible.
Yeah.
But yes, been a fan for a long time. I grew up in State College, so I've been to lots
Oh,
of
did you really?
Penn
Okay.
State football games. I
Yes.
guess the
All right.
best one I've ever been to was the 1982 Nebraska game. It was really pretty cool. They never had lights at the stadium. They trucked them in. It was the first time they did a night game there. It's really fun atmosphere.
Yeah.
1982, Brad.
Yeah. I've been to one game ever at Happy Valley, and it was when LeVar Arrington was there, but the scene was just incredible. People were there, days before in Winnebago's, just tailgating and hanging out, waiting for Saturday to come around.
Right.
Yeah. All right. Well, thank you both very much. I don't want to take up any more of your time. I appreciate you guys both coming on. And we will be sure and include any resources or links to your information.
Great. And feel free to delete those fun facts, okay?
Yeah, okay, gotcha. All right. Thanks, guys.
All right,
Thanks,
good night.
Nathan. See ya.
Take care.